acute altitude illness. So if you go too fast to altitude, or you stay too long at the high altitude, like at extreme altitude or at the death zone, you are at risk of acute altitude illness. And we've got three types of acute altitude illness: AMS, acute mountain sickness; Hace, high altitude cerebral edema; and Hape, high altitude pulmonary edema. So those are three acute altitude illnesses. So what is the epidemiology of acute mountain sickness? So the symptoms, they usually appear over 2,500 meters, and that's the borderline for the acute altitude illnesses. Okay, so that's the lower altitude. It's very rare to have the patient with those illnesses. The symptoms appear after between 4 and 24 hours after reaching the new altitude. Okay, so quite quickly. And above 3,000 meters, around 30% of trekkers have acute mountain sickness. And on Kilimanjaro, where acclimatization rules are rarely obeyed by the companies which organize expeditions there, the risk of AMS is like 50 to 75% in the last camp. So what are the symptoms? The headache is the most important symptom. Okay, it has to be a headache to diagnose the acute mountain sickness. And then there should be at least one of the following. So a loss of appetite, no need for food, nausea, vomiting in most severe cases, lethargy, sleep disturbance, dizziness, apathy, peripheral edema. So actually the headache, the lack of appetite are the most and some lack of energy are the most evident symptoms of acute mountain sickness. It's called high altitude hangover because the features of the acute mountain sickness, the symptoms are very similar to hangover. Maybe some of you will be able to compare those two problems or have a little, at least a little bit experience with one of those problems, AMS or hangover. And the therapy, what's the therapy for the AMS? So if you are at the altitude of 2,500 meters and you've got symptoms of acute mountain sickness, you shouldn't go higher. You should avoid going higher. Because if you will go higher, AMS will change into Hace, high altitude cerebral edema, which might end in death. Okay, so it's very dangerous. So do not hire, avoid overload, rest. Take rest, day, 2 days to acclimatize better. Hydrate yourself, so drink a lot, eat a lot, just force yourself to eat. And take ordinary painkillers like paracetamol, ibuprofen, some antiemetic drugs like ivermectin, and observe your organism. Observe your organism. Observe for 24 hours. So if the symptoms will not improve within 24 hours, or from the beginning they are quite severe, so you've got severe headaches, severe vomits, severe nausea, then you should descend. Descent is the basic therapy for all acute altitude illness. So descend 300 to 1,000 meters or until symptoms will disappear. That's the best therapy. If you've got emergency oxygen, use oxygen with the flow to 4 liters per minute. If you've got pulse oximeter, try to reach the saturation over 90. You can use hyperbaric chamber if there is no way you can go down because of, for example, the environmental conditions like avalanche danger or stuff like that. And you should use drugs. The first choice drug is dexamethasone, 4 milligrams every 6 hours. There's, of course, special dose for children. And use acetylazomide orally, 250 milligrams every 12 hours. In acute mountain sickness, you are conscious, so you take the drugs orally. And you go down. The oxygen bottles are very light. They are composites made. Here you've got an example of the oxygen bottle at Nanga Parbat expedition. That's how the mask looks like. So we are getting used to masks during the pandemic, so it shouldn't be a problem for a climber to use the oxygen mask during the therapy. And the oxygen flow in such oxygen sets, in maximum is 6 liters per minute. So not as in hospital, 15 liters per minute, but 6 liters is enough. The hyperbaric chamber is a chamber in which you put the patient, you inflate the chamber, and you can reach in the chamber higher pressure than it's outside the chamber, to 0.2 atmosphere higher than outside of the chamber, which for the climber means that he is around 2,000 to 3,000 meters at the lower altitude. So the climber inside the chamber virtually descends. So that's quite a clever way of descending. So that's when it comes to acute mountain sickness. So headache, like altitude hangover, descent, and dexamethasone in the therapy. When it comes to high altitude cerebral edema, the symptom starts at a higher altitude, around 4,000 to 5,000 meters. An average altitude at which Hace is present is around 4,700 meters. And it starts when you are over 24 hours at the new altitude. So it's not very, it doesn't have very rapid presentation. And over 3,000 meters, like around 1% of climbers develop high altitude cerebral edema. So it's less, let's say, frequent than AMS, which is quite common. The symptoms, very severe headache and neurological symptoms. Like 60% of patients, they have ataxia, so they have awkward movement, they have imbalance, so they can, let's say, fall, they have problems with movement, so they might behave like drunk person, okay? So AMS, hangover, haze, very drunk patient, okay? Changes in the consciousness are in 70% of patients, so the climber might become like aggressive, might have some hallucination, might be disorientated, might behave very strangely. So changes in behavior, confusion, hallucination, and then after a prolonged time, a few hours, a day of haze without therapy, the patient gets into coma because of the brain edema. And then there is respiratory and circulatory arrest and death, okay, if nothing is done. So what's the therapy? Here we do not wait. Here, if you will diagnose or observe imbalance or some confusion among the climbers, you should order descent 300 to 1,000 meters until symptoms disappear. That's the best, that's the main therapy of acute altitude illness. Then during the descent, you can use oxygen, the same rules as in AMS, and use dexamethasone. Here, it's better to choose intravascular or intravenous way of giving it, especially in patients who do not cooperate or who do not want, who are in coma. So here the difference between Hace and AMS when it comes to dosage is that the first dose is bigger. You give 8 milligrams of dexamethasone and then 4 milligrams every 6 hours. You can use acetylazomide and hyperbaric chamber in case you cannot descend. And the third problem, high altitude pulmonary edema. So the symptoms, the third illness from 3 or acute altitude illnesses. So the symptoms start over 3,000 meters. The same as in Haze, they appear when you spend more than 24 hours at the given altitude. The Hape can develop during the several days, but sometimes it takes shorter time and it's enough for the respiratory failure, so it's quite tricky. Around 0.5% of climbers develop Hape over 4,300 meters. But if you directly would reach the altitude of 4,500 meters, then among those climbers, 10 times more, so 6% of patients got Hape. And the older you are, like the patients over 67 years, they're at 3 times higher risk of Hape. So what are the symptoms? The symptoms are similar to pulmonary edema, which you can see in the hospital due to cardiogenic cause. But here it starts, let's say, it's tricky start because the first symptom is significant reduced exercise tolerance. So among the group of climbers, you've got one which is taking rest a lot of time, which is always at the back whose pace of climbing is very low. So if you would observe such symptoms, you should, let's say, check if that's not the beginning of Hape. Then the patient gets breathing disorders, have higher frequency of breathing, has dyspnea on exertion and then dyspnea at rest. And that's for 70% of patients. So problems with breathing at high altitude, you should think about high altitude pulmonary edema. Then the blood in foamy sputum is present in advanced form. The patient might have perceived the bubbling breathing, and then the respiratory failure comes, and then respiratory arrest and cardiac arrest. So what's the therapy? The descent, as I told you, but here 1,000 meters is minimum, is the basis of the therapy. Then you use oxygen on the way down. You can use hyperbaric chamber in case you cannot go down. You shouldn't lie down the patient in supine position because sitting position is better for the respiratory failure. And then there's a drug which is called nifedipine retard, but you use it only when descent and oxygen are not available. If you can descend and give oxygen, do not give that drug. You can also give phosphodiesterase inhibitors like tadalafil, sildenafil, in case the descent oxygen and nifedipine is not available. So that's for the Hape therapy. And here you can see one of my friends with high altitude pulmonary edema at the advanced base camp at Everest from the north side. And he's very tired. He has problems with movement. He's receiving oxygen. And we have decided to go down. So it occurred that we were too fast reaching the top. Within a few days at the altitude of 6,400 meters, and Darek developed Hape.
Powiedz parę słów. Nie słychać? Słychać. Ja pochodzę, tak boję się, że wejdę jutro.
So he's telling that he's barely walking and he's afraid that he won't be able to descend the next day.
Schodzimy. No Darek otrzymuje tlen. Tutaj przepływ jest 2 litry na razie na minutę. No zobaczymy.
So he's receiving oxygen 2 liters per minute. And we decided to go down. So here you've got a film after a descent of 300 meters. Okay, so we descend.
Jesteśmy 300 metrów niżej niż na BC. Jakaś różnica w ogóle czujesz, Darek, czy nic? Nie czujesz.
So I have asked Darek if he feels any difference, if he feels better, but there was no result of the descent.
Czyli za mało jeszcze.
Okay, and then we are around 1,500 meters below the Everest Advanced Base Camp. And the same day, after a few hours.
Szczerze, nie, my się bardzo dobrze idziemy. Bo ja tak dotąd to jeszcze dociągnąłem całkiem, wtedy wiesz, naprawdę dobrze.
So as you can see, he's now talking with more comfort. He's not so afraid of his life now. He feels better, and now we are analyzing what was the main reason of the problem, why he had developed Hape. As a matter of fact, he was one of the team members who didn't go through the acclimatization process because he was just before, let's say 1 month before the expedition to Everest, he was on the winter expedition, so he thought that his acclimatization is good. That's why he developed Hape, because of the lack of acclimatization. So maybe a few words from Darek.
Zacząłem coraz bardziej stawać tam właśnie na dłużej stanąłem.
He's telling that on the way up, he started to more and more frequently stop and taking a rest, so feeling exertion.
to był chyba ten pierwszy moment, a potem to już
And he says that that was the first moment that something was going wrong, and then, as you've seen, the things were going worse and worse. Okay, so to summarize, the prevention of acute altitude illness, AMS, Hape, and Hace, the most important things are to acclimatize, to watch one another, to notice, observe symptoms, inform the guide or the team leader about the symptoms, and do not underestimate anything that happens to your friends, and act, okay? Even if you feel tired, you reach the camp and you see your friend not feeling well, something is wrong, you have to descend, you have to give oxygen and descend. That's a bibliography. I recommend going to the modern medicine advice and recommendations from the UIA webpage. You can find a lot of medical recommendations for high altitude. And if you've got any comments, just write them. You can visit my webpage. Thank you very much for attendance, and we've got it.